Okay, so let us look at the last part of this, that is the long essay. Describe the etiology, pathogenesis, clinical features and management of carcinoma tongue. Correct? Carcinoma tongue, that's what it looks like. For 10 marks, you have to explain carcinoma tongue. So first, always start off with the anatomy also. So it looks like what we look at is the dorsum of the tongue. So here they are showing you the fungiform papillae, filiform papillae, foliate papillae, circumvallate papillae. Then here you are showing you the palatine tonsils. Do you know where I am pointing? Yeah, the palatine tonsils here, right? And then they are showing you the vellicula. Okay, so this is the tongue, and here they are showing you the inferior surface of the tongue, where they are showing you the frenulum. What are they showing you? The frenulum is in the middle. Then you have the deep lingual vein, and then you have these things which are the plica fimbriata. Okay. Draw diagrams, you will get marks. Very simple ones also, just draw them. And here they are telling you the extrinsic muscles of tongue. You have some extrinsic muscles of tongue. Glossus, 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 glossus. So you have the palatoglossus, hyoglossus, styloglossus, genioglossus. The nerves are the vagoaccessory and the hypoglossal nerve. Okay. So here you have the anterior 2/3 of the tongue and then the posterior 1/3 of the tongue. You can see the sensory is the lingual branch of the V3. Here you can see the sensory, for this is the lingual branch of V3 from the trigeminal. This is a lingual branch, right? And for taste it is chorda tympani from the facial nerve. So facial nerve, chorda tympani. So if you are able to touch anything with the tip of your tongue and tell the taste, that is because of your facial nerve, chorda tympani. Okay, then behind what you have for the posterior, for sensory and taste, it is one only, that is the glossopharyngeal nerve, which is going to be a 9th nerve, 9, which you write like this Roman number. Okay. So in the textbook, now let us look at carcinoma of tongue. They are talking about the pathologic type. So you have the non-healing ulcer. Okay. So there is an ulcer which does not heal at all. So that is a non-healing ulcer. Okay. So on the lateral border of the tongue it will be. So if this is the tongue, this is the lateral border of the tongue, right? So somewhere here there is a non-healing ulcer. Okay. So this could be a carcinoma. Then a proliferative growth with everted edge. So if this is the tongue, there is some growth here with an everted edge. That means everted edge. Okay. So there is a growth. Frozen tongue or indurated variety. Induration means what? Hardening, something, right? That's what we read. So there's a frozen tongue. The tongue is converted into a hard woody mass. Then fissure variety. The tongue is indurated with deep fissure. So fissure is more like a cut, right? That is what is a fissure. There's a cut. There's an opening on the tongue. Okay. So how will they present? Now, let us look at some images. Wait. A bleeding ulcer, they will present with an ulcer. So here they are showing carcinoma, tongue lateral border, the most common site they are showing here. Then they are showing frozen tongue, ankyloglossia and dysphagia are present. What do you mean by dysphagia? You cannot swallow. What is ankyloglossia? Tongue, ankylo. What is ankylo? That's more like a tongue tie. What is it? A tongue tie. They cannot move the tongue freely. Okay, then here they are showing carcinoma of tongue with ankyloglossia, disarticulation. That's something to do with the teeth, isn't it? And dysphagia. Okay. Then what is this? Carcinoma, posterior 1/3, easily missed. So you wouldn't see at what is there at the back. So you would easily miss it. So that's what they are trying to say, I think. Look at this. Let's highlight it. Here. In the back of the tongue. Are you able to see? Here, at the back of the tongue, here, to be more specific. There you go. Okay. So then they're talking about carcinoma tongue excavating ulcer. Then you have carcinoma tongue left lateral border, everted edges and excavating. Here also, everted edges, excavating. Then you have carcinoma left border tongue in 40-year-old man. Okay. What is this one? Here they are showing this man with some marking on his chest. Carcinoma tongue with absolute dysphagia, fixed lymph nodes in the neck and involvement of the mediastinal lymph nodes receiving radiotherapy and Ryle's tube feeding. Okay, what are all these marks? But so these people will come to you with what? Some bleeding ulcer from the tongue. Then you have bilateral massive enlargement of the lower deep cervical nodes So in an elderly patient, that can be suggestive of a carcinoma of a posterior 1/3, okay. He may not even know that there is a growth at the back of his tongue. Now, some pearl of wisdom they're telling here, tongue cancers tend to be more rapid in their onset than other cancers. So it is very fast, it will come, it seems. So, tongue cancers have great potential of lymph node metastasis. That's why they said they will come with enlargement of these nodes. Now, clinical examination, how will you examine this patient? First, let us look at this diagram here. So, lymphatic drainage of the tongue they're showing here. So, here you can go, the tip of the tongue goes to submental, then some of these lateral and middle part are going to submandibular, then this part at the back of the tongue, they're showing it to near the internal jugular vein, they are draining, okay. So, what are we trying to look at? Yes, we are trying to look at the carcinoma of tongue. I have a tongue tie. I'm having a dry throat actually. Okay, so how will you examine the person? Inspection, palpation, all that you will write. Digital palpation you have to do of the posterior 1/3 of the tongue. So you have to put your gloves and then palpate, and you should not make him get gag reflex. Okay, be careful. So the ulcer bleeds on touch, they are saying, typically, right? And the surrounding area can be indurated. Surrounding area are indurated. That means hardened. Then check for the mobility of the tongue. Forward, it should be genioglossus. This muscle is mostly involved, so they won't be able to do looks like. Then backward, stylo. Back is stylo. And elevation is palato. You're going to touch the palate. Depression is hyoglossus. So all these muscles, you're going to check which nerves are affected. Hypoglossal nerve mostly. And then you have the palatoglossus. I'm thinking that is for the palatoglossus. Except palatoglossus, which is supplied by the glossopharyngeal nerve. Backside, you know, no sensory and taste, everything glossopharyngeal only. Bidigital palpation of the mandible should be done. So you'll palpate mandible area also, okay, which may show thickening. Then lymphatic spread, we told you, right, how it will spread, all that we told you in the diagram. So this is another pearl of wisdom here. Posterior 1/3 of tongue has very less cornification, but has abundant lymphatics, which explains massive nodes. So it has abundant lymphatics, let us know, the posterior 1/3 of tongue, okay. So massive nodes will be there because of this, because it has abundant lymphatic drainage. So investigation, what you do, you will take a biopsy, then orthopantomogram. What is this? Orthopantomogram. X-ray of the mandible can demonstrate the irregular defect due to invasion, erosion and pathological fracture. Okay, so this is the X-ray of the mandible, basically they're telling. What are we looking at? Carcinoma of tongue. Now let's look at this box here. Carcinoma of posterior 1/3 of the tongue. There will be dysphagia. There will be change in voice. There can be change in voice, right? You can miss it unless you, they're telling, right, you palpate at the back. Then biopsy you should do under general anesthesia, obviously, because this patient will not cooperate for you, right? And palpation, we told you, right? You can feel induration. Mainly they're telling about this word induration, very important when you palpate. Then you have to look for, this is one of the occult primaries for lymph node secondaries in the neck. Okay, so this is the primary for the lymph node secondary in the neck. Crisscrossing of the lymphatics explain bilateral lymph nodes of the neck. So why bilaterally it gets affected is because there is crisscrossing of these lymphatics. That's what they're saying. So that is bilateral lymph nodes are affected. Okay, that's what they're saying. Blood spread is more common. So why did we learn lymphatic drainage? That blood spread is more common, they're saying. Prognosis is bad. People, it is very bad. Why did they say this happens though? Bad dentures and etc. Is it? Causes, I didn't see them tell at all. Chest X-ray you can do to rule out anything. Routine investigations, etc. you will do. Treatment. Carcinoma of tongue, similar to any other carcinoma of the oral cavity. What you do, you have to preserve the function of the tongue, remember, and then you will have to radiotherapy. So carcinoma in situ, what will you do? Partial glossectomy, hemiglossectomy. That means little portion of the tongue gone. Hemiglossectomy, around 50% of the tongue gone. Total glossectomy, they are saying. Glossectomy. Then how will this person ever eat? This can carry significant mortality and morbidity. So they are showing here in this diagram partial glossectomy. So this portion, the lateral lesion, whatever they are trying to remove, hemiglossectomy where 50% of the tongue gone. There's one thing called as a commandos operation where what they're doing, carcinoma of the tongue, if it is fixed to the mandible, okay, if it is involved with the mandible, removal of the floor of the mouth and radical neck dissection. Wow. That will look very, very scary to look at that person. He'll have to go for a, recreation of all that. So in a radical block dissection of the neck, what and all is done, you can look at that here. So radiotherapy they are talking about for the lymph nodes, then you have to retain this internal jugular vein at least on one side, they are saying, to prevent cerebral edema. Obviously the brain has to drain, not in brain drain. But causes of death in carcinoma tongue. So recurrent aspirational pneumonia can be there. Yeah, because this guy has dysphagia, right? He might go and swallow into the lungs and cause himself an aspirational pneumonia. So obviously there can be recurrence, and what else? Hemorrhage. This is what bleeds on touch. Even after there's so much of hemorrhage from growth. Wow, we told you a lot about carcinoma tongue. Draw a lot of diagrams and you will get marks. Okay, people, did you understand? Commandos operation is there. Carcinoma of tongue. Okay, commandos operation. Radical neck dissection with some glossectomy. It's hemiglossectomy with hemimandibulectomy. Hemiglossectomy with hemimandibulectomy. Okay.